Hi, good evening, good afternoon, and good morning, everybody. I am Dr.Mohit Bhandari from Indore in India, and I welcome all of you for the 23rd episode of Virtual Bariatric University, along with Professor Fobi here, which we are organizing in order to bring about the information and spread the information of bariatric and metabolic surgery to young fellows, surgeons, and colleagues from across the world. Today, we will be discussing about laparoscopic banded gastric bypass, a bariatric and metabolic operation. Let me have this honor of introducing the faculty for today's course to all of you. Let's start with Professor Luc Lemmens from Belgium. Professor Luc Lemmens is the head of surgery at Sint-Niklaas, Belgium. He's a bariatric surgeon at AZ Riverland in Belgium. Is the pioneer of obesity surgery in Belgium, performing bariatric surgery since 1982. I was born in the year 1980, and just 2 years after that, Professor Luc Lemmens started the bariatric surgery. So you can imagine that he is almost 38 years into the service of bariatric surgery. A team led by him was the first center of excellence in Europe, recognized by the International Federation for Surgical Obesity. He was the president of the European chapter of IFSO in 2008 to 2010, the president of IFSO EC Congress in 2014, a founding member of the Benelux Association of Bariatric Surgeons, a founding member of the Belgian Obesity Surgery Society, which transformed into Belgian section for obesity and metabolic surgery later on. Is a treasurer of BOSOMS, which is the Belgian Society for Bariatric Metabolic Surgery. And nowadays, his most frequent operation are banded gastric bypasses and banded sleeves. My association with Professor Luc Lemmens goes back in 2012 when he first visited my center at one of the OSCE meetings which was organized. And that time, he did a banded gastric bypass and operated live at our center. And also, we started our animal lab at that time, and Professor Luc Lemmens was there to train the fellows and surgeons from all across the world at our center at the newly inaugurated animal lab. So Professor Lemmens, you have a huge amount of experience. It's an honor to have you here, and I know most of the meetings we discuss about our data on banded sleeves and banded bypasses, which is almost in parallel. And I think we agree on almost everything because we are the ones who are doing these procedures in these numbers and following up on the data. Welcome you again, and we look forward to have insights about your experience on this procedure, which is a better modification, or I would say the correct modification of Roux-en-Y gastric bypass, which is not a very good operation because of a lot of weight recidivism. Next, we have from Brazil, Professor Caetano Marchesini. Caetano is a great friend. He's a great human being. My association with him started because of Professor Fobi, but then we become great friends, and he invited me to Brazil almost in 3 meetings successively. Caetano is a bariatric surgeon at Hospital Sírio-Libanês Hospital Marcelino in Brazil. He's the chief of Department of Endoscopy in Marcelino Champagne Hospital, and Curitiba, scientific director of Brazilian Society of Bariatric and Metabolic Surgery, the former president of Bariatric Society for Bariatric and Metabolic Surgery, the member of the executive board of the IFSO, and the international member of ASMBS. He is a speaker for Merck Sharp and Dome and Cot Pharma in USA, on the advisory board of Medtronic for Latin America, and also on the advisory board for bariatric surgery of Novo Nordisk. Caetano is a very bright surgeon, very famous surgeon, and one of the most accomplished bariatric surgeons from Brazil, not only because he's in the leadership, but also because he's extremely skilled and has performed thousands of these procedures in Brazil. Welcome, Caetano. We look forward to have your insights upon the banded procedures. Next, we have Dr. Michael van der Bosch from United Kingdom. Michael is a general surgeon with special interest in laparoscopic GI and bariatric surgery. He joined the medical specialist group in Guernsey, Channel Island, UK in 1999. He works as a consultant general surgeon at the Princess Elizabeth Hospital of the island. He's also a consultant surgeon at Spire Hospital in Southampton, where he's a founding member and lead of the Department of Bariatric and Metabolic Surgery. He completed 2 years fellowship in advanced laparoscopy with Professor Himpins before taking up his first consultant post in Brussels in 1997. He introduced the concept of mini gastric bypass in UK in 2010, when there was no enthusiasm for this procedure. And Michael, let me tell you, the same time around, a year after, myself and Professor Kular here from India introduced this concept to the Indian set of surgeons, and we were absolutely ridiculed. And I think I could imagine the amount of hard work which you would have put into to introduce this mini gastric bypass to the United Kingdom, which has now paved the way for many surgeons in United Kingdom practicing this procedure. Thank you, Michael, for accepting our invite, and we look forward to have your views, your opinions during the entire presentation. Next, I have Dr. Felipe de Cruz from Spain. Dr. Felipe is a professor of surgery in Medical School of University of Madrid in Spain. He is the head of Department of General, Digestive and Transplantation Surgery in University Hospital of Madrid. His practice of bariatric surgery began in 1986. Again, one of the very, very old and accomplished bariatric surgeons. And he performed the Lemmens gastric bypass facialistic tube ring, which is the initial version of this banded gastric bypass young surgeons like us perform today. He did the first laparoscopic bariatric surgery in 1999, and that was a banded gastric bypass. The founding member and past president of the Spanish Society of Obesity Surgery. He's a past president of the Spanish Society of Obesity Surgery Foundation. Welcome, Professor Felipe. It's an honor to have you. We have had the honor of your hospitality during the IFSO meeting, and which we organized with Professor Antonio Torres, and always it's an honor to learn from you. I have another friend, Dr. Ahmad Bashir from Jordan. Ahmad is a minimally invasive GI and bariatric surgeon at Jordan Hospital. He is the founder and director of GBMC Jordan Hospital in Amman, surgeon champion of metabolic and bariatric surgery accreditation and quality improvement program, Jordan Hospital, the chief of Department of Surgery at Jordan Hospital, and chairman of communication committee at IFSO. So very important post, Ahmad, which you hold in the IFSO, and we have been appreciating all your work which you have been doing for IFSO since last 1 year. And I personally am a testimonial to the kind of work you do. Really fantastic, and it's an honor to have you here. Just to mention, Ahmad had some previous posts. He was the director of the first annual GBMC Jordan Hospital Bariatric Conference, and also the member of scientific organizing committee of the first virtual IFSO Congress in 2020, which was a phenomenal success. Welcome, Ahmad. We are honored to have you, and we look forward to interact with you during the course of the program. We have our friend from Brazil, again, Dr. Everton Cazzo. Dr. Everton is a digestive and bariatric surgeon. He's an adjunct professor of Department of Surgery of the Faculty of Medical Sciences at the State University of Campinas, master's and PhD degree in surgical sciences at State University of Campinas, fellow of IFSO, Latin America Federation of Surgery, the Brazilian Society of Bariatric and Metabolic Surgery, and the Brazilian College of Surgeons. Everton is a researcher on bariatric and metabolic surgery and also hepatobiliary and pancreatic surgery. His main fields of research, which brings him on this course, and very aptly so, is banded Roux-en-Y and banded OAGBs, the NAFLD and the insulin resistance. Everton, we have heard about your research, and we would want your insights so that all of us can learn from it about your experience on the banded procedures, because I heard from Professor Fobi and many other surgeons like Almino and Manuel that banded gastric bypass was practiced in huge numbers in the Brazil, and we want to understand what happened in the present time about the banded gastric bypass practice in Brazil. And I think you can give us insights about that because you've been researching on this topic for a long time now. Thank you very much for accepting this invite. A warm welcome to you. I have another friend, one of the most brightest surgeon, one of the most top leader in bariatric and metabolic surgery, Professor Rachel Moore from United States of America. Rachel is a metabolic surgeon and obesity medicine specialist at Surgery Specialists of Louisiana. She's the president of Louisiana chapter of American Society for Metabolic and Bariatric Surgery. Rachel has special interest in endoluminal obesity therapies, and that's a common interest which I have with Rachel, and heard a lot of her presentations in meetings organized by Manuel and Abu Dhabi at different platforms about the endoluminal obesity therapies, which I would say are no more than new kids on the block, but they are having a very important place now in the algorithm for the treatment of obesity. Rachel serves as an instructor for Orbera gastric balloon since 2015, has a huge amount of experience in the intragastric balloon, and she has trained innumerable number of doctors, surgeons, gastroenterologists in US and across the world for best practices for Orbera intragastric balloon. This is one area, the intragastric balloon, where very less number of surgeons across the world have got good insight and experience. And Rachel is one of them. Welcome, Rachel, on this program. I think you are for the first time at the virtual Bariatric University. And I hope this camaraderie goes a long way, helping the science grow and helping all of us learn, innovate, and move forward. Finally, my consultant at our hospital who did a fellowship under Professor Fobi and me, and now he is a consultant since last 3 years. It's a proud moment for me to have Manoj Reddy from India. Manoj is a laparoscopic bariatric surgeon, and now he's based in Indore. He's a part of Mohawk family. He's an assistant professor in the same medical school to which all of us are attached, where Professor Fobi is a clinical professor along with me, and we serve the department. He has trained under Professor Fobi and myself and now works as a full-time consultant at Mohawk Bariatric and Robotic Surgery Center. He has completed his general surgery at Narayana Medical School in Nellore and has done multiple publications and presentations in bariatric surgery. Welcome, Manoj. God bless you, and may you scale more heights, and we look forward to interacting with you. Finally, I, along with my teacher, my mentor, Professor Fobi, who designed the concept of virtual bariatric university amidst the time of COVID pandemic, where everybody across the world is not able to attend these fantastic lectures by stellar faculty like all of you, to have it go across the world beamed on high definition platform. At this time, I would like to invite Rachel, Everton, Caetano, and Ahmad to moderate the first lecture session. Thank you, all of you.
Rachel.
Rachel and Caetano, can you unmute? Thank you.
Yes. Thank you, Dr. Fobi and Bhandari, for the honor of participating. I'm reintroducing our first speaker, Dr. Luc Lemmens, who's an extremely important contributor to the fund of knowledge about our subject. He's been a pioneer of obesity surgery in Belgium since 1982, former president of the European chapter of IFSO, founding member of the BABS. And for the audience, one of his important papers published in the journal Obesity Surgery in 2017 should be easily downloadable for any IFSO member, and it's a valuable resource on this subject. Dr. Lemmens' topic today is weight loss outcomes after banded gastric bypass.
Bashir.
Good afternoon, everybody. Thank you, Dr. Bhandari and Dr. Fobi, for inviting me. So, my name is Luc Lemmens. I'm working in Belgium, in Bornem. It's in the northern part of Belgium, and also in Brussels in Delta Hospital. I have only a teaching relationship with bariatric solutions, and these are my case mix disclosure. I already started bariatric surgery from the beginning of my career, and in the first 20 years we did especially BPDs following Caetano, and we did more than 2,000 of these procedures. And then in the beginning of 2000 we started with the gastric bypass, and as you can see, most of them are banded, more than 1,330 cases, and only more than 300 non-banded. We also did sleeves, especially banded ones, and some mini bypasses also. We started with Fobi ring, and we used it for several cases, a few hundred cases, and it worked very well. But one of the problems was that the teeth of these first rings could break. And that was one of the reasons we changed to the minimized ring already in 2012. And then what's the advantage of this ring is that it's only one ring, and you can easily place it through a 5mm trocar, what is easy, especially in redo operations. And there is also a needle with a soft tip. It's easy to bring it around the pouch in between the vessels, even without dissecting, and especially easier for banded sleeves. We do, of course, a long vertical pouch, 6 to 8 centimeters in length, and we don't care too much about the length of the pouch, because we know that the pouch will end where the ring is placed, because this is a fixed outlet. We start with small rings, 6 centimeters, 6.5 centimeters in females and males, but this gives really too much restriction or dysphagia. And then most of our rings were done with 6.5 and 7 centimeters for females and males. But now, in the last years, we enlarged again a little bit, and we use now 7 and 7.5 centimeter rings. We published our data already in 2017 in obesity surgery, and it was a cohort study of 432 patients with a complete follow-up of 5 years. We could follow all of these patients for 5 years, and we compared 255 non-banded with 178 banded patients. The BMI was a little bit higher in the banded group, 2 points more, and it was nearly 42 BMI. And the mean excess was also 10% higher. Mean excess rate was 10% higher in the banded group. The result in percentage excess weight loss, and you see that at 5 years, there is a difference of 9% better results in the banded group. And you see that there's a tendency of weight regain in the non-banded, while the banded patients, the curve stays nearly horizontal. And the same if you look at the weight loss, with a difference at 5 years of 8 kilograms in advantage, with an advantage of the banded group. And if you follow the patients for 8 years, we still see that there is a big difference of 6% extra points in BMI loss. In the banded group, there is some weight regain also in the banded group, but there is more weight regain, of course, in the non-banded group. This is the scatter plot of our study at 5 years, and you see that the standard deviation is smaller in the banded group, and so that means that the results are more consistent than if you compare with the non-banded patients, and that most of our patients are above the 50% success rate of Reynolds. We looked also at the weight regain at 5 years, and then you can see that in the banded group, nearly 46% have no weight regain at all, while there is only in 26% of the non-banded group with no weight regain. And there are no patients with more than 5 points BMI gain in the banded group. early complications, there were no band-related complications, and even till now, we have nearly 2,000 banded procedures. We have no really band-related problems. The late complications, there's no big difference between the different group, but again, in this group, in this study, because this is the results of the published group, there were no band erosions in this group. We also looked at the dumping, but because we hoped that there should be a difference if you compare banded and non-banded group, but you see that we couldn't find it in this study. And we had some broken bands, as I already mentioned, and but we also had some functional stenosis of the rings, and but we come back to that later. And then if you consider all our banded bypasses, we have found 7 migrations, which makes 0.5%. 3 were in redos after redo operations, and 4 also in primary bypasses. The symptoms, mostly those patients come because they feel some pain, small pain, or mostly maybe only dysphagia. And then, of course, we have to do a swallow test, and it's important also to do a gastroscopy. Don't go immediately in for a laparoscopy, because if you see a migration of the ring, you can take them out by endoscopy, what makes it easier and better for the patient. Because if you do surgically, this is not the same as the big, as the migration of the big bands before, because these are really small pouches. There's a lot of fibrosis, and then you make a hole you have to close, and it's not always easy because you have also to prevent stenosis, of course. So this was our pictures of only 3 days ago. This was the last migrated band we had to take out by endoscopy, and this is how it looks. Patient could leave the hospital already the same day, but we kept them for security till the next morning. Another complication is slippage. So this, we can see different kind of slippages. So this is an example of slippage where the band is lying on the gastroenterostomy. It's difficult to say if it is stenosis on an ulcer or something on the gastroenterostomy. But if you went in, the ring was really a little bit came down and was lying on the gastroenterostomy. So we could replace easily the ring a little bit higher, fix it again. So we had 6 slippages, documented slippages at least, but 2 were on the jejunum, and these are emergencies. These patients also coming in with acute dysphagia. And one of the patients, she waited too long, and so we had to resect the anastomosis and a part of the alimentary limb. So one patient was the limb was really on the anastomosis, the picture I showed you. And the 3 were just lying on the pouch, and then you can see that the pouch is hanging a little bit over the ring, same little bit as you can see in the big with the previous adjustable rings. So normally we can replace them above, we open it a little bit, replace it higher, and fix it again. So normally what you have to do is you do, of course, a swallow test, and always, as I told, a gastroscopy. We have to be sure that there is no migration. And then normally we try to replace the ring, because this ring can only slip and there is not enough fibrosis around the ring. Normally the ring is fixed by some kind of fibrosis, but some patients don't do any fibrosis at all. So these rings, they loosen around the pouch and they can slip. So what we try to do is fix it a little bit better. We place some momentum on top of that, if we can, or some patients ask for removal of the ring. Stenosis at the level of the ring, we also see that, and this is the opposite as with slipped rings. Some patients make too much fibrosis, just like we see in breast implants. And then in this we will see also at the swallow test that there is stenosis. Again, do a gastroscopy to exclude migration. And these patients normally you have to go in again. You find a lot of fibrosis around the ring. Sometimes when it's not too much, in one patient I try to keep it inside, and the ring could stay inside. But mostly you have to remove the ring, because this will, even if you take the fibrosis out, it will come back, and the patient will come back for ring removal. So what about the functional stenosis? This is not a too big problem, but some of the patients that are complaining about late dysphagia, and then you do a gastroscopy and they say everything is completely normal, no stenosis at all. But sometimes you can suspect something on a swallow test. But if you go in, because patients are they continue to complain, then we see that sometimes the ring is migrated into the liver, or that the liver is hanging on the ring. And that's what I think is a problem, that when the patient is eating, that they're sitting up and the liver is hanging on the ring. It causes some kinking, and especially will cause problems for solid food. So it's easy to, but we just do an arteriolysis of the ring, we fix the ring on its place again, and again we put some multimeter. But on the other hand, you have also patients really they're incompatible with stenosis, or they're compatible with these problems and the fact that I cannot eat. So what we do is we enlarge the ring in some patients, but sometimes they insist before removal. So late operations for weight regain, these are published data again of the 5-year follow-up. And then in this group, we didn't have any patients already operate for weight regain, and there already were 10% of patients reoperated in the non-banded group. And what is our strategy for patients with weight regain in the non-banded gastric bypass? So what are the best candidates for placing a ring? These are volume eaters that have not too much weight to lose, and when you see on X-ray there is not a dilated pouch, you can put a minimizer. But if you really in this case you find a really dilated pouch, better you have to resize it, because if you don't resize you will cause some kind of an hourglass, and those patients will vomit. So we have to resize it and then place the minimizer. Of course, be careful for sweet eaters and grazing, but then the ring will not have the good results. We can also distalize it if you like, but this is not the topic of my talk. And then what about eating habits? Again, this is from the published data. You see, of course, that the non-banded group is doing better, of course, but much less complaints. But of course, they have the risk, of course, of the weight regain. But if you see, these rings are too small. But in the group of 6.5, 7 centimeter, they're doing much better. And even now with half centimeter larger, there are much less complaints about dysphagia. So to conclude is that for us, the banded gastric bypass is our first choice operation. And just placing a ring takes you a few minutes. It's really fast. And we know that more than 45% of the patients had no weight regain at all, versus only 26% in the non-banded group. That there is a 40% higher excess weight loss after 5 years. There are no operations for weight regain in the banded group yet. There are few band-related problems, but at least less than 5%. And let's say the more important complication, just as migration, is 0.5%, or slippage is even less than 0.5%. We have them, but the percentage is very low. And what's the best length of the ring? Maybe now what we do now is 7 in females and 7.5 in male patients. Because at least they have a better quality of eating, and maybe the results at the long term are not so different. So thank you for listening. Thank you.
Great job.
Thank you, Dr. Lemmens, for your excellent and thorough presentation of your vast experience. I'm interested in, is there any time that you would not recommend a banded bypass to a patient? For example, have you noticed particular patient characteristics that you can tell ahead of time they would be better served with a different procedure?
There are different reasons why not to do a ring. I think you have to be careful with redo operation. That's maybe the first part of your question. Mm-hmm. Because we saw the first 2 or even 3 migrations was after a redo operation. So I think it's important when you place the ring, you need some healthy tissue, and there may be no tension on the gastric wall. And then it's, of course, it's the same discussion. If you have to talk with patients, if they say, I have to eat a lot, some patients say, I have an important job and I live on the restaurant doing whatever thing, jobs, whatever. I think you have to be careful then, because they will not be pleased if they cannot eat. So what in those patients I do now a mini bypass with a little bit of larger pouch. And if I put the ring, I put the ring at least at 7 centimeters there. Maybe is this the answer?
Yeah, I was just interested. What about, do you ever do esophageal function studies, with the additional obstruction?
No. No, we don't do it. What I'm also afraid is in patients with huge hiatal hernias. Because what we saw, no, we needed a study, because on the other hand, the ring is large enough, because it's not the same as on the adjustable bands. So I don't change the passage. It's only when they eat too fast that they will have a difference. But I'm afraid of hiatal hernia. And so because and also what we have seen is that when there is, okay, we close the pillars and whatever, you put a ring, but sometimes those patients come back because the procedure of the pouch is slipping again into the chest, but the ring will be hanging at the pillars, and that's one of the problems that and much more. But in some patients, I will even don't know if there is a hiatal hernia, but when there is a ring, then they will start to form, because I think the ring is hanging there. It will not go into the chest with the rest of the pouch.
That makes sense. And for young people like me watching who are thinking about adding this procedure to their practice, what advice would you give to someone who is interested in, what's your best advice to somebody who is just starting?
Look, that the ring is not too small, because there may be no compression of the pouch. So make your pouch small enough, and then fix the ring at least with 1 or 2 non-resolvable stitches. I believe in that, because if they don't do any fibrosis, then the ring will be too loose and they will slip. So at least you have 1 or 2 stitches needed to keep them in place for the first period. And just, I think before the operation, talk with the patient. This is the most important thing, because you have to tell him that he will eat less at 6 months or 1 year, not in the first 3 months, but that at 6 months or 1 year or later, they will eat less than other patients with a gastric bypass. But they have to explain well, and that's important to explain well, that that is the choice they have to make, or the risk of having weight regain, or the risk of eating a little bit less. But what is amazing is that most of them, they learn to live with it. We have not so many complaints at the long term that by dysphagia. It's amazing, and even I have at least as many patients asking for making the ring smaller than making the ring larger. So sometimes in the redo, I'm afraid of putting at 7, so I leave 7.5. And recently, some patient asked me make it a half centimeter smaller because I eat still too much. So I think you have to talk with the patient. That's the most important here.
Does the adjustability of the ring accommodate that? You could go back at another procedure and you could make it tighter?
Yeah, I think, and that's another thing you have to explain, because some patients that still think that, oh, that is too small, I'm vomiting, but okay, now I'm stick with that. No, they can come back, and 1 day surgery takes 10 minutes to make the ring larger. So, and this is also one of the advantages of this ring, because it's replaced by, if the ring is broken, okay, these rings cannot break, but replace the ring, it's not always easy because you have some fibrosis. Everything is possible, of course. So this is so easy to open and close it. But again, talk with the patient is the most important part, because I will see some patients of colleagues without the ring and they will eat more. So again, you will explain them what will be the difference.
Wonderful. Thank you so much. Do any of the other panelists have questions for Dr. Lemmens?
Yes, I would like to go ahead. Please go ahead.
Please, Caetano, you started first.
Well, we've been doing, yes. Hello, are you listening to me? Do you have my audio?
Yeah,
It's okay.
I'm there.
Okay. So what happened is we've been doing banded gastric bypasses. When we started doing these bypasses back in 95 till the 2000s, so we did more than 3,000 gastric bypasses banded. For one thing, it would be important to tell you guys, we did the bandits as the old-fashioned way with the mesh. So we did have some more problems with the mesh. On the contrary, we're having today better materials and not having so many complications as erosions. But when you have a material like a non-groupable to the tissue material, you tend to have more slippages, you tend to have more displacements. And I saw the numbers are not so big as I imagined that it would be, because I don't have many experience of this. But one thing I can talk about banded gastric bypass is that some patients, they really do not adapt and they continue the life term vomiting, and they have really serious problems with that. This is the first thing I think this is why I stopped doing banded procedures, because I believe that the quality of life of these patients were not very good. Another thing I see that some patients tend to adapt, and they change what are they eating for soft things and more carbohydrates. So we get a weight regain secondary to that. And a third thing we have is a dilation of the proximal part of the pouch. So this can lead, secondly, as Rachel was asking, to a problem with the esophagus too, this motility. Not for the first 5 years, but now we have patients that did the surgery like 20 years ago, 25 years ago, and we are seeing some small dilations of the distal esophagus. I would really like to hear your comments about that, sir, and tell me if your experience is different.
Okay. Until now, because let's say vaginal dysmotility, I've seen a patient. I remember one. Maybe there are others, but in the study I showed you, we have a follow-up of 90%. So in this group, I'm sure there was nothing except if there were in those 10%. But when you expect with this kind of bands we can open, and I think you have to explain again and again and again that they can come and that you can open it, because even if patients are vomiting and I tell them, please, I will take a ½ centimeter more or even 1 centimeter, or I can take it out. Most of them, they will refuse because they're afraid of regaining weight. Second thing of pouch dilatation is you have to place the ring high enough. And if you place them at 4 centimeters, I've never seen a dilated pouch of when the ring is placed high enough. I've seen some, but one of my colleagues once did a ring, and I've seen it later that it was a little bit lower. It was on the sleeve, I remember very well. And we had to go back after a while to put it higher, because then there was a dilatation with slippage. So And again, that's why I think we are going to place a little bit larger rings. I think with 7.5, my thumb can go through, and you will not have dilatations with 7.5 or even with 7. I've never seen it, but with the smaller rings, that's a big, can be a problem, but I'm not aware of that, of these mobilities.
Do you control these
Maybe
patients
somebody
with
else has
endoscopy?
comment on that, but
Do you?
But not standard. But if they're coming, that's why I'm telling every patient is coming with some complaints. Now we do more and more gastroscopies because I have to be sure there is no migration, and I always do a gastroscopy when a patient is complaining before going in. I like to have a swallow test because then you can see a little bit better the physiological how the liquid is going through, and if there is some stenosis or not. You can see it well if on a swallow test also. But then we always do a gastroscopy, and we have a really few. I cannot. Recently we had one with when the patient has stenosis, and that's because of the fibrosis. Those will do some esophagitis. But normally, in most of those, we don't have any problems on that. And I think the difference is we make the ring large enough.
Thank you. Ahmad, please.
Bashir?
Thank you, Caetano. Thank you, Dr. Lemmens, for this great beginning lecture. I'm always interested in the basics of things since part of the audience is young surgeons. How do you standardize this procedure in your practice, as far as how did you decide on the location where to put the band? That's first. And the size of the ring, does it change between one patient to the other, or is it the same size? That's my first question. Second question, I think you defined it in your paper, but just to the audience, how do you define weight regain after gastric bypass? That's number 2. And number 3, it's a lot, I know. Is there a particular patient population that you think they would gain the same result in a non-banded Roux-en-Y gastric bypass? Can you avoid using a band in certain patient population? Because we tend to be either banded Roux-en-Y gastric bypass surgeons or non-banded Roux-en-Y gastric bypass surgeons. And somehow there has to be a middle ground between. That's my third question. And the most compelling question that we face is cost. Who covers the cost in Belgium? In private practice, patients paying out of pocket for people who are not covered by in their countries, it's a significant added cost. How do you face these issues? Thank you.
Okay. The first one, standardizing. We always we do a bypass on a 34 French tube and a sleeve. We do it on a 40. But let's say in the first primary operation, you place the ring now, and recently the publication of Cazzo, they also changed them, placing the ring a little bit higher. And now, because you have to see the OG junction, more or less. So, and we try to place it now at 4 centimeters. I prefer even 3 than 6 now. We do a little bit higher, just I'm going the pars condensa, just below or just in the condensed part of the small omentum. And then the ring is placed in a primary operation. In female, we do always now 7, and in male, we do 7.5. Why? There is no logic about that. Maybe on the other hand, I think most of the men are more meat eaters, I think. But okay, you can discuss about that, but that's what we do.
Okay.
So, and then on a redo operation, that's completely different.
Okay, I'll do that.
Different because when the wall is thicker, we want to avoid any compression of the wall, and then we do 7.5. The same what we do in a mini bypass also, then we do a 7.5 because we make the pouches a little bit larger. What is weight gain? I think some patients come see you when they regained 5 kilograms or even less, and they are afraid, and so they come too early. And of course, you cannot operate on them at that time, but then you send them, of course, to a dietitian. But other patients come when they regain most of their initial weight. And these are not good candidates neither, because Dr. Van den Bossche will talk about it. I've seen about the redo operations. I have the impression that in redo operations, except with when everything is enlarged and you can resize whatever, but when it's not a dilated pouch, the results, they will lose 5 or 10 kilograms, but not more than that. And so what is weight regain? It's what the patient feels as a weight regain. So that's why I mentioned also, that's why I did put zero weight regain 46%, and that's why I did put, I think it's what the patient wants. The third
Okay,
one.
this time we're going to move on to the next speaker. Some of these issues will be addressed by the next 2 speakers. So Cazzo,
okay,
let's go ahead to,
Okay.
yeah. Cazzo?
No.
Everton?
Okay, whatever.
Cazzo,
I have to do
Mr.
something,
Everton
or
is going to be
about
talking.
the cost. The patient is paying for that. Sorry. Do I continue or not?
No, let's go to the next speaker, please.
So maybe one word. Okay.
Yeah, we have at the end of the discussions, we have time, but I want to make sure every speaker has an opportunity to finish his or her
No
sentence.
problem.
Yeah. Everton?
Hello, everybody.
Go ahead.
It is a pleasure and a privilege to take part in this event. And I would like to invite Dr. Manoj Reddy to present his lecture. Dr. Manoj Reddy is a laparoscopic and bariatric surgeon who's based in Indore, India. He is an assistant professor in the Department of Surgery at Shri Aurobindo Medical College and PG Institute, Indore. He is trained under Professor Dr. Fobi and Dr. Mohit Bhandari, and works as a full-time consultant surgeon at Mohawk Bariatrics and Robotics, Indore. Dr. Reddy will present a lecture on a comparison of banded gastric bypass, and one anastomosis gastric bypass.
Hi, good morning, good afternoon, good evening, everyone. Firstly, I would like to thank Dr. Fobi and Dr. Mohit Bhandari for giving me opportunity to present in 23rd episode of Virtual Bariatric University. Today, I'll be presenting on banded gastric bypass versus mini gastric bypass, or one anastomosis gastric bypass versus Roux-en-Y gastric bypass for the treatment of obesity. I'll be giving the comparative study for the 5-year follow-up. Greetings from our center. This is where I work, Mohawk Bariatrics and Robotic Surgery, based on Indore, India. I have no disclosures to make, and Dr. Fobi is the founding president of Bariatric Corporation, and Dr. Mohit Bhandari is consultant to Johnson & Johnson Medtronic Bariatric Solutions, Intuitive Surgical, Colstro, Stryker, Apollo Endosurgery, Pentax, and Olympus, and they have nothing to do with this study. This is our case mix disclosure. Total of 14,297 procedures were performed at Mohawk Bariatrics till now. We do all kind of procedures, including sleeve gastrectomy, bypass, one anastomosis gastric bypass. Even we banned all these procedures, and endoscopic sleeve gastroplasties, balloons. And coming to my presentation, as you all know, the gastric bypass is considered to be the gold standard of treatment, surgical treatment for obesity, as published by Dr. Fobi et al. And as the time passes by, the gastric pouch dilates, and the anastomote, the bowel, jejunal part which we anastomose to the bowel also dilates, leading to the weight regain. So Dr. Fobi introduced placing the band around the pouch of gastric bypass 2 centimeters above the GJ, and it is documented to produce better and sustained weight loss when compared to non-banded gastric bypass surgery. And we are comparing these two surgeries with one anastomosis gastric bypass, oblique mini gastric bypass. It was introduced by Rutledge in 1997. It was technically simpler and easier to perform when compared to gastric bypass, and it's easily reversible. The purpose of the study is to compare weight loss, metabolic syndrome outcome in patients of all the 3 procedures, and to analyze the postoperative complications and long-term nutritional effects pertaining to these surgeries. This is the patient profile. We compared 82 patients from banded gastric bypass with 90 patients in one anastomotic gastric bypass to 122 patients in Roux-en-Y gastric bypass. As you can see, there is not much difference in age profile, and body weight is almost equal, like 120, average body weight is 120 kgs in banded gastric bypass and 130 in one anastomosis gastric bypass and 115 in Roux-en-Y gastric bypass. And BMI is almost equal, like 44, average BMI is 44 in BGBP, 46 in MGB, and 42 in OAGB. And coming to comorbid conditions, 41% of patients are diabetic in BGBP group, whereas 37.7 in MGB group and 21.3% in RYGB group. And hypertension, there are almost no significant difference, and OSA is almost equal in all these patients. The follow-up, we have follow-up of around 60%, 61% at 5 year in banded gastric bypass group, whereas 63.3% in MGB OAGB group and 67.21% follow-up at 5 year in RYGB group. This is the percentage total weight loss graph. As you can see, the peak weight loss is achieved in MGB at 3 years. After that, patients start to regain a little bit of the weight they have lost. The peak percentage total weight loss is around 37.68% at 3 years, whereas at 5 years it is 34.72. Whereas in BGBP group, the peak weight loss is around achieved at 3 years, and later that the weight loss is plateaued. The patients didn't gain much of the weight they have lost, and there is still continuing weight loss. Whereas in Roux-en-Y gastric bypass group, peak weight loss is achieved at peak total weight loss is achieved at 2 years. Later on, patient starts regaining weight from there on slowly. At 5 years, the total weight loss is 24.01%. This is the percentage excess body weight loss graph of comparison of 3 procedures. As you can see, same here, the percentage excess weight loss of 82.2% was achieved in MGB group at 3 years. Followed, then patients regain a little bit of weight. At 5 years, it is 78.08%. It's same in our BGBP group, where the highest excess body weight loss achieved was 75.43% at 3 years. Later on, patients regain a little bit of weight, and basically the weight has plateaued. They haven't regained much of the weight. Whereas in RYGB group, the highest weight loss achieved was excess body weight loss achieved was 69.91% at 2 years. Later on, patients started regaining the weight, and at 5 years, the total excess body weight loss is at 60.68%. And this is the resolution of comorbid conditions graph, showing almost 71.42% resolution of diabetes in banded gastric bypass, and 79.16 in OAGB, and 61.9% in RYGB group. This is at 5 year. And hypertension resolution is almost equal in MGB and BGBP, whereas a little bit less, 43% in RYGB group. This is because of the weight regain. The patients, so they have some patients have stopped the medication. They have started again medication because of the weight regain in RYGB group. And the sleep apnea has shown very good results of around above 90% in all 3 procedures, and dyslipidemia is almost equal in all 3 groups of the patients. This is the chart showing, this is a very important chart. It shows percentage weight loss at 2 and 5 years. Less than 50% of excess body weight loss, which is considered as failure in according to many papers. Less than 50% of weight loss was seen in 3.1% patients and 3.2% patients in BGBP and RYGB respectively at 2 years. And 50 to 75% of weight loss at 2 years was seen in 42% in BGB group, 76% in OAGB group, and 8% in MGB group, whereas above 75% at 2 years was seen in 92% in MGB group, followed by 54% in OAGB group and BGBP group, and 20% in OAGB group. And as you can see, when it's compared to at 5 years, less than 50% weight loss was seen in 6.1% in RYGB group, and none of the patients from BGBP and MGB group had less than 50% of weight loss. Whereas in 50 to 75% of weight loss was seen in 41.5% in RYGB group, followed by 32% in BGBP group, followed by 25% in MGB group. The highest of above 75% of weight loss was seen in 75% in MGB patients group, and 68% in BGBP group, followed by 52.40% in RYGB group. This shows that 6.1 patients have had a failure rate in RYGB group, but none of the patients from MGB, BGBP group had a failure post-surgery. And MGB has a very good weight loss of around above 75% in 75% of the patients, whereas in BGBP group it was seen in 68% patients. Nutritional deficiency. This is the most important chart to be considered. As you can see in BGBP group, HB less than 11 gram is seen in 2.4% before surgery compared to 12% after surgery. Whereas in OAGB group, it was 19.3% people had a hemoglobin less than 11 post surgery, and it's 14.6% in RYGB group. Coming to albumin, 6% of patients experience low albumin level, that is less than 3 in BGBP group, and it's 10.5% in OAGB group, the highest, and it's 7.31% in RYGB group. A protein percent of less than 6 gram per DL is seen in 29% previously before surgery, and it's 38% post surgery in RYGB group, BGBP group, sorry, and it's 42%, the highest in OAGB group post surgery, and in OAGB group it's 21.95%. And the rest, vitamin D3, B12, calcium level doesn't have much of a significant difference. And 2 patients had albumin level of less than 2.5%, and 2.5 in MGB OAGB group, and none of the patients from BGBP and RYGB group had a albumin level less than 2.5, and one of the patients underwent reversal of the surgery as albumin level was 2, and then another patient had albumin level of 2.4 who was treated conservatively with albumin transfusion and feeding jejunostomy, feeding gastrostomy. It worked well, and patient recovered, and then he was good on protein diet, and he was managed conservatively. Whereas one patient underwent reversal of these 2 patients. The complications: the one patient had a reversal in BGBP group, and one patient had a staple line leak. Anastomotic leak in MGB group, which was detected 5 days post surgery and then repaired there itself in the same admission. 3 patients had a marginal ulcer, all of them treated conservatively, and 1 patient underwent reversal. The reason for it I explained in the before slide. And 2 patients had hemorrhage, 1 underwent surgery, and another was treated conservatively with transfusions. Whereas in RYGB group, there was 1 patient with hemorrhage, which was treated conservatively. Band erosion was seen in 1 patient in banded gastric bypass. Endoscopic removal was done. That is 4 years after the surgery. Patient came with complaints of pain and burning sensation in the epigastric region, for which endoscopy was planned, and we have seen the band and removed it in the same sitting. The conclusion of the study is like OAGB, BGBP, RYGB are all equally excellent good operations for weight loss. Resolution of metabolic syndrome is almost equal in all 3 operations. And the percentage excess body weight loss and resolution of type 2 diabetes mellitus is significantly higher in the OAGB MGB group, at the expense of increased incidence of nutritional deficiencies and hypoproteinemia. Long-term follow-up multi-center prospective studies are needed to confirm these intermediate to long-term outcomes. Thank you.
All right, Everton.
Congratulations on your fine presentation, Dr. Reddy.
Thank you, sir.
Your group clearly demonstrated that there is a clear tendency to better weight loss in the one anastomosis gastric bypass at the expense of some nutritional issues.
Yes.
On the other hand, I thought that your results clearly demonstrated that the major weight on the 3 procedures were achieved around 2 to 3 years, and then a tendency to some weight regain was almost universal.
Yes, sir.
At least not so pronounced in the banded gastric bypass.
Banded gastric bypass, yeah. Weight plateaued, whereas in both the groups, weight regain was there.
Yes. And also on the one anastomosis gastric bypass, this tendency to weight regain was even less pronounced.
Yes, sir.
I have a few questions to present to you. Do you think that although one anastomosis gastric bypass present a slight tendency to weight regain after 3 years, putting a band in this procedure, is it possible to bring some benefit, especially in individuals with a BMI over 50 kilograms per meter square, for example?
Yes, sir. Basically, we used to take a MGB limb length of 250 centimeters before. The study I presented is 250 centimeters limb. That time we had few cases of reversals because of excess weight loss and protein energy malnutrition. Then Dr. Fobi has joined us in 2017. Then we divided, we brought the BP limb length to 180 centimeters, where we have seen weight regain. So we started putting band around MGB pouch at around 3 to 4 centimeters from the GE junction for the super obese people with BMI over 50. It's an ongoing study, sir. We are doing it right now. We'll let you know the results in a few years.
Okay, thank you. And with regard to one anastomosis gastric bypass, is there a protocol for endoscopic surveillance of these patients?
Yes, sir. We are doing endoscopic surveillance. After 6 months to, 2 to 5 years post surgery, we used to do regular post endoscopy for the patients who ever visited our OPD. But we have data of 200 patients, 200 to 250 patients, where we have a marginal ulcer rate of around 11 to 12%. Of them symptomatic being 2% and non-symptomatic being 8 to 9%. I mean, patient come to OPD with no problems, nothing at all. They were happy with surgery, but we find a small marginal ulcers. But almost all marginal ulcers got relieved by pantoprazole infusion itself. We keep the patients for 24 to 48 hours. We give them pantoprazole infusion. And one patient had a very big marginal ulcer where we were supposed to post him for surgery. But Dr. Fobi and Dr. Mohit were in Kenya. So we waited for him for the reversal. And we put him on pantoprazole infusion. When they returned, we did an endoscopy and the ulcer was gone. We were about to reverse the patient because ulcer was that bad. Within 48 to 72 hours, ulcer has vanished. No.
Okay, thank you. And finally, for individuals which presented with weight regain after sleeve gastrectomy, which one of these 3 procedures do you think it's the best for a revision?
Banded gastric bypass. We have data to this.
Is it your routine?
Sir, come again.
Is it your routine procedure for this case?
Yes, sir. Banded gastric bypass for weight regain post sleeve gastrectomy.
Thank you.
Thank you, sir.
And now,
the panelist has a question.
I have a question as well.
Go ahead.
Yes, can I? Thank you, Dr. Reddy, for this nice presentation. I
Thank
got a question or two. In your results, you saw marginal ulcers only in the OAGB, but not in the Roux-en-Y or the banded Roux-en-Y. Normally, those bypasses have a similar incidence of marginal ulcer.
Yes, sir. Yes.
What is your explanation for finding these in OAGB? Is that related to technical things or any other explanation?
Sir, in this study, the patients which we took, we didn't do surveillance endoscopy, sir. We only did endoscopy for the patients who complained coming to the OPD that we have pain in the epigastric region or anything else. Okay, so we have started doing surveillance endoscopy post this study, sir. In 2019, when Dr. Fobi has given us the protocols to find out how many patients have asymptomatic ulcer, that's when we started. And even that is halted now because of this COVID situation.
Okay.
Otherwise, if we do endoscopy in all the patients in gastric bypass, maybe we might find 2 to 4% rate of marginal ulcer, which was mentioned.
My second question is, what do you do with smokers? Are they excluded from bypass surgery, or do you operate on them? Or do you offer them also bypass?
We explain them about their marginal ulcer post surgery in smoking, sir. If patient is ready to quit smoking, we go with bypass, or else we do sleeve gastrectomy. After explanation, if patient is willing enough, then we go with surgeries.
Okay, thank you.
May I have a last question, Mo?
Yeah, go ahead, Keita.
Okay, just one concern. I got all those. It's very nice presentation. Congratulations. There's only one thing I saw there. You had like the same number of albumin under 3 for groups banded and not banded. And I would expect a banded a little bit bigger because patients have some intolerance. So how could we explain this?
Because the BP limb and rule limb are almost same. So maybe the band is just, we added a band for restriction purpose, that malabsorption is less.
Do you understand what I'm saying? Because what
Yes,
I'm thinking is that if the patient has a band, he has more intolerance to eat meat.
Yes,
this is something common we see, and this is not happening here in your. So I'm sorry, and I'm sorry. What I didn't understand your answer. Could you repeat it, please?
Because
let me try to address that question. In India, it's unique. The protein the patients take in is mostly vegetable protein.
Oh,
the only difference between the regular gastric bypass and the mini gastric bypass is that they do all have a certain amount of protein deficiency, but we only see severe protein deficiency in the mini gastric bypass with albumin less than 2.5. But in all the gastric bypasses, there's a diminution of the protein level. They're almost equal because most of the protein, a good percentage of the Indians are vegetarians and they chew their vegetables, and so their protein intake is about the same among the 3, except that it's worse in the OAGB.
Oh, I see. Thank you, Mo. Thank you.
Yeah. Any other faculty member has a question for Dr. Reddy? Okay, we'll move on. Caetano, I think you are next.
Yes. Well, for me, it's a great pleasure to introduce Dr. Michael van den Bossche. He is joined the medical specialist group in the Guernsey Channel Islands in UK in 1999. He works as a consultant general surgeon at the Princess Elizabeth Hospital on the island, and he also is a consultant surgeon at the Spire Hospital in Southampton, where he's founding member and lead of the Department of Bariatric and Metabolic Surgery. He introduced the mini gastric bypass in the UK in 2010, when there was no enthusiasm for this procedure. He completed a 2-year fellowship in advanced laparoscopic surgery with Dr. Jack Himpins before he started to do the service. He'll talk to us about the outcome of banded gastric bypass as a revisional procedure. Please, Dr. Michael, start your presentation. Thank you very much.
I want to thank Dr. Fobi and Dr. Bhandari for their kind invitation to give this talk on banded gastric bypass as revisional procedure. In my talk, I will discuss surgical options to deal with weight regain after gastric bypass and my own experience with banded Roux-en-Y gastric bypass for a failed Roux-en-Y. I have no financial disclosures. This is my case mix. Weight regain after Roux-en-Y gastric bypass is not uncommon and is significant in up to 25% of patients. Weight regain increases as years go by, and after 10 years, the percentage of excess weight loss is down to 50% or less. Roux-en-Y gastric bypass is not an operation that lends itself to an easy reintervention to induce significant weight loss. The results of different types of revisional surgery are often short-lived, not significant, and can come at a significant cost of complications. Most publications are short case series. Long-term data are mostly absent. In short, one literally has to maneuver in a minefield. This painting refers to the Oracle of Delphi, where ancient Greeks went to ask the gods for advice, and to a certain extent did applies to revision of Roux-en-Y gastric bypass. Several options to deal with weight regain after Roux-en-Y have been described. These include sclerotherapy, placement of an adjustable gastric band over the pouch, placement of a silastic ring, revision of the gastric pouch and the gastrovaginal anastomosis, distalization of Roux-en-Y, conversion to BPDDS, the Rose procedure, the use of stoma fix, etc. This large series from Al-Bader reports on reduction of the gastric pouch in 170 patients. Excess weight loss at less than 20 months was 29%. The reported complication rate was 15% and the reoperation rate 3%. Dacre and Impens reported an early experience with banding of the pouch using a silicone ring. They treated 6 patients who had regained approximately 10 kilograms, and after 1 year of follow-up, they had again lost that extra weight. There were no complications. Muller reported in 2005 on resizing of the gastric pouch and redo of the gastrovaginal anastomosis. This was a small series of 5 patients. There were no complications, and patients dropped 4 BMI points at 1 year follow-up. Gobel published on the use of an adjustable gastric band as a salvage procedure for weight failure after Roux-en-Y. Again, this was a small series of 11 patients with no complications. At 1 year follow-up, the excess weight loss was 21%, and the patients dropped on average 6 BMI points. A very interesting publication by Dr. Bookwald in 2017 on lengthening of the BP limb to treat inadequate weight loss after Roux-en-Y laid bare the dangers associated with this technique. Like Scopinaro always said, it's very dangerous to add restriction to malabsorption or add malabsorption to restriction. 53 patients were followed up for 5 years. The BMI dropped from 47 to 31. While there was no operative mortality, the complication rate was scary. There were 3 late deaths. The 30-day complication rate was 13%. More than half of the patients suffered late complications, malnutrition being the biggest problem. 43% of patients required TPN at some stage, and a quarter of patients required revisional surgery to reduce malabsorption. Jack Impens reported his outcomes on revisional surgery for failed Roux-en-Y gastric bypass. They performed a variety of procedures from conversion to distal bypass to a variety of restrictive operations. What is striking again in this series is a complication rate of 20% and a reoperation rate of 7.2%. The leak rate was an impressive 12.1%. Hamdi reported his experience with pouch reduction and refashioning of the gastrovaginal anastomosis in a series of 25 patients. The complication rate was low with only 1 reoperation for a small bowel obstruction caused by a trocar site hernia. Patients did drop 5 BMI points at year 1, but by year 2, they had not only regained the weight, but put more weight on, as shown here by the BMI number. Another publication from Kashishian reports on conversion of Roux-en-Y and VBG to duodenal switch. Not surprisingly, the outcomes on weight are excellent, a 67% excess weight loss at 30 months, with complete resolution of preoperative symptoms. We all know that the DS comes with a higher complication rate than any other bariatric procedure, and this was reflected in the 13% leak rate for Roux-en-Y patients. Interestingly, none of the VBG patients had a post-operative leak. Conversion of standard Roux-en-Y gastric bypass to a distal bypass for weight loss failure and metabolic syndrome was reported more recently by Gyasi and Kelvin Higa. This series reports on 96 patients. 11 patients had a lengthening of the BP limb, whereby the total alimentary limb length was kept to 250 or 300 centimeters. 7 out of 11 patients developed calorie and protein malnutrition. The subsequent patients all had a revision whereby the TAL was 400 to 450 centimeters. They report an excellent weight loss of 65% at year 3, and patients dropped on average 8 BMI points. The 30-day complication rate in this series was 6.3%. The total reoperation rate was 12.5%, and it consisted mostly of limb lengthening to tackle malnutrition. A lot of patients were low in albumin, calcium, and vitamin D at year 3. This brings me to my own experience with conversion of Roux-en-Y to banded Roux-en-Y for weight regain. 42 patients underwent this type of revision. 3-year follow-up data were available for 29 patients. The vast majority of these patients were female. The average age was 46, and the interval to revision was approximately 5.5 years. All patients were investigated by means of gastroscopy and barium study. The original BMI before the primary operation was around 46. The nadir BMI after primary bypass was 27.8, and the pre-revision BMI was 38.4. As far as the operative technique was concerned, in 22 out of 29 patients, the pouch anastomosis and proximal small bowel were reduced in size by sleeving that complex. A new anastomosis was created for 24% of patients. In all patients, the candy cane was resected. A bougie 34 to 36 French was used. 9 patients underwent a change of their limb lengths. In 7 patients, the alimentary limb was marginally increased from 80 to 150 centimeters. And in 2 patients, the BP limb was lengthened from 100 to 150 centimeters. A gastric bypass ring or a Fobi ring was used in all patients. 27% received a 6.5 centimeter ring, and 73% had a 7 centimeter ring placed. The mortality was 0%. The leak rate was also 0%. Excess weight loss was 88% after 3 years. But I can tell you that following those 3 years, 4 patients did develop again weight regain. The complication rate was 14%. 1 patient sustained a splenic injury during conversion, requiring open surgery with splenectomy. 2 patients had an anastomotic stenosis requiring 1 successful endoscopic dilatation, and 1 patient developed a small bowel obstruction caused by band adhesion, treated laparoscopically. This graph shows the weight over time. 3 years after revision, the weight is almost the same as the nadir weight after the primary Roux-en-Y gastric bypass. The BMI graph has got an identical pattern. So in conclusion, revision to banded Roux-en-Y gastric bypass is safe and feasible in selected patients. Weight regain can and will occur in some patients. Like I mentioned before, 4 patients developed weight regain after the 3 years. The pouch size does matter. In all patients, a pouch reduction was essential to allow placement of the Fobi ring. Much can be said about limb lengths. I do not think that the small changes in limb length in 1/3 of my patients contributed significantly to the outcomes. Operations can be technically challenging, and one should expect a higher complication rate. More interesting in current times is the use of non-surgical measures to induce weight loss. GLP-1 agonists like liraglutide and semaglutide are now available to induce weight loss, and these medications are currently my first choice to treat weight regain in patients who had the Roux-en-Y gastric bypass. Many thanks for your attention.
Thank you, Caetano.
Yes, put the audio on. Sorry, Mo. Well, very nice revision of literature and very nice thoughts about treating these weight regain patients. I've been doing endoscopy and endoscopic treatment for weight regain since 2009 with argon plasma, and I have a very big experience in Brazil. Probably is one of the biggest experience in that. And we are always concerned about these patients because this is a special type of patient. The non-responders, these guys are really tough to respond. And when we see the literature talking about revisional surgery, first thing we can see is that there's a very low number. The numbers are not big. We do not have one only surgeon, a big experience to tell us really what is important. What we can feel here is that using the band by your presentation, Michael, is that we have the less complications or severe complications that we are concerned about, mostly about nutritional complications, but we still have intraoperative and postoperative complications related to the band, and even that we have weight regain in these patients. So I believe there is a place for to band these patients, but I still, here in my practice, we have a high volume practice. I do try drugs, as you said, semaglutide and liraglutide, and I do try first doing endoscopic treatment. And we have a very nice rate of weight loss, and we can always have the option that for surgeons is a little bit scary, is that about the possibility that endoscopically you can always redo your procedure. And for surgery, every time you think about coming back, you think always about complications and what these can bring to our patients. So another thing I saw in your presentation, Michael, you should comment, is important, is that there's some bias when you get the pouch trimmed. We know this can have an effect. And do you use the drugs, even these patients that go through revisional surgery?
Okay, so those patients is an older group of patients, and I think the Roux-en-Ys that were revised into banded Roux-en-Ys were probably where the pouches were relatively large when they were originally made. So technique evolves, so what you did 10 years ago is probably not quite the same as what you do now. So drugs, unfortunately, these drugs are expensive, and patients can't get hold of them unless they pay for it themselves. So a month worth of treatment with, say, semaglutide or liraglutide is easily £100. So people have to pay for this. It's only licensed for people with diabetes. Now, none of these patients were diabetic. These were patients with just weight regain. And they all had regained more than 50% of their excess weight that they had lost. So I think for people who can afford it, it's a nice thing. They avoid an operation with all the risks, as you've seen in all those series. It's very frightening when you have a splenic injury or a splenic artery bleed and you have to convert to open. So on those occasions, I think I'm very lucky that I can operate with the help of another consultant. We often do dual consultant operating, which I think contributes to the safety and an instant quality control on the work done.
Okay, so a last question, just here in our practice, we have a psychiatrist working with us because we do understand these patients really do have eating disorders. Some of them have severe eating disorders. And we do, with our psychiatrists, prescribe some drugs like topiramate, as fluoxetine, as bupropion, and other drugs that psychiatrists use for these eating disorders. Do you do this with your patients previously to a revisional surgery or after the revisional surgery?
Patients all go through an MDT assessment, which includes surgeon, anesthetist, bariatric dietitian, and a bariatric specialist nurse. A psychologist is also involved, but just a level below. That's tier 3. We are at tier 4, where people actually are considered for surgery. But the psychologist plays a role just before they come to us. They come with a recommendation for surgery. That is for the NHS, the National Health Service patients. Now, in this case, I must tell you that all these patients were self-funding, because in the National Health Service, people cannot have a Fobi ring or a minimizer ring. It's not allowed. So they can't even co-fund this. If they want this, they have to go completely private, which is a sad thing. But
yeah. Does the panel has any other question?
I have a question. Thanks for the interesting presentation. Everybody's always trying to figure out what to do for patients with weight regain. It's always a hot topic among bariatric surgeons. I'm interested in the intraoperative decision where on some occasions you were sleeving, the pouch anastomosis and so forth, and on other times you were completely revising the gastrojejunostomy. What makes you choose one versus the other intraoperatively?
it's just it was part of an evolution. At some point, you were dismantling everything. We undid every anastomosis, resected the bottom of the pouch, so you had to do new anastomosis. But as we progressed with other experience, we just put a bougie down and then sleeve along that bougie to sort of try to standardize it. And also for closing the Fobi ring, what we used to do is keep the bougie in place, put the ring around the pouch, use a sort of a perigastric approach that gives a better fixation. Because those rings, like Luc Lemmens says, some people hardly make any fibrosis. When you go back for some other reason, it's like just a film of transparent tissue that covers that ring, but there's no great fixation. So keep the bougie in place, place the ring then. The difficulty with the gastric bypass ring was that when you opened one, that was the size you sort of had to work with. And if you made the wrong choice, quite an expensive mistake. The minimizer,
so the sleeving over the bougie is your more current technique?
Actually, I hardly do any Roux-en-Y gastric bypasses now. I've sort of abandoned that, and I do much more MGBs, OAGBs. So Roux-en-Y is not one of my preferred procedures these days. Not every patient is a good case for a revision to a banded bypass. There was a time when surgeons made micro pouches. So these patients who can have significant weight regain because they lose all restriction, it just goes straight through in a dilated small bowel. There is no pouch to put a ring around. So these are not really good candidates when the pouch is too small. Yeah.
Thank you.
Dr. Bashir, go ahead.
No more questions?
No, I think we'll move on to the next moderator.
Thank you.
Thank you.
Thank you, Michael.
Thank you very much.
Thank you for involving me in this talk. And our next speaker is Dr. Felipe de la Cruz Vigo, who's a very experienced surgeon, professor in surgery in medical school in the University of Madrid. And he's head of Department of General Digestive and Transplantation Surgery in El Hospital 12 de Octubre in Madrid, Spain. And he's a founding member and past president of the Spanish Society of Obesity Surgery. And as Mohit Bhandari mentioned, he practiced, he has a vast experience in bariatric surgery. He started in a long time ago in 1986, performing Lemmens gastric bypass with the silastic tube ring. Dr. De La Cruz, please go ahead.
Dr. Bhandari, for the invitation to participate in this webinar. It's for me a pleasure and an honor also to share this session with such distinguished colleagues. My talk is about reintervention after banded gastric bypass. I have no conflict of interest. In my case mix, banded gastric bypass represents around 90% of my bariatric surgical experience. I began in 1986 and I have done BBG, gastric bypass, scopinar operation, and all in open surgery. The Lemmens banded gastric bypass was the first operation for obesity I performed. The silicone ring was on the gastroenterostomy and erosion was very frequent. Almost all my laparoscopic bariatric experience has been done with this operation, an adaptation to laparoscopy of the Capella's technique. Firstly, we use a silicone ring with 6 centimeters perimeter. Soon we had the stenosis and erosions and decided to switch to polypropylene mesh band following Capella's recommendations, but with 6.5 centimeter perimeter following Fobi's experience. Since then, we use a 7.5 polypropylene mesh band that we close at 6.5 centimeters, passing it behind the pouch through the lesser omentum and closing it with 2 clips. This is the way in which we place the band. We open lesser omentum nearby the stomach and 2 centimeters above the place for the future gastroenterostomy. And with a right angle forceps, we pick up the band and pass through the lesser omentum. And then we close with 2 clips the band that is very loose around the pouch that is really narrow. And this is the position of the band at the end of the operation, 2 centimeters above the gastroenterostomy. In our manometric studies, the band causes a pressure augmentation on the reservoir, but without a sphincteric behavior. 2 systematic reviews were published about banded gastric bypass, one by Bogwald, in which reoperation bar related were 4.1%, and other by Mahawar, in which non-silastic rings had less erosions and band removal rate than silastic ones. Erosion are more frequent in silicone band rings, and a significant number of them can be left in place to be spontaneously extruded. Endoscopical removal is possible as well as laparoscopic one. To prevent erosions, band must be above the gastroenterostomy with a perimeter of 6.5 to 7 centimeters without the stitches or sutures to fix it. Fobi reported in 2001 1.63% erosions, almost 20% of them spontaneously extruded, and 30% endoscopically removed. In 2005, after the introduction of laparoscopy, he had less than 1% erosions. Hennigan reported 1.5% with one removed by endoscopy. The incidence of stenosis is the same for silastic and non-silastic bands. They need surgery to be removed, although dilation is sometimes used. For its prevention, 6.5 to 7 centimeter perimeter bands are used and calibration tube over 34 French. Vomiting and intolerance of meat and bread without stenosis are frequently reported also. Moon performed balloon dilatation in 2.2% strictures he had. Lemmens removed 5 rings for functional stenosis, 2.8%. Also 2% had more fixed experience. Santé, vomiting and poor tolerance to meat reports that doesn't support the use of banded GBP. Racera reported 24.4% vomiting, and Bessler only finds intolerance to meat and bread greater in the banded patients without reporting stenosis. Slippage is rare, only seen in silicone rings. They must be removed, although 1/3 of them will be replaced. To prevent it, the band must be placed through the lesser omentum and above gastroenterostomy. Slippage is less frequently reported. Galal reports 0.7% with reposition of the band. In Oliveira report are together migration and slippage, which is confusing to understand the article. Better experience has Bhandari with a 7-centimeter GABP ring without erosions and finding significant better results of banded gastric bypass. Poor weight loss and weight regain can reflect nutritional deviation and or anatomical technical modifications with the passing time. If there are no technical problems to correct, malabsorption must be added. In summary, reinterventions are more frequent in elastic ring, in which can be easier to be treated endoscopically. Polypropylene mesh bands can be complete or partially removed. Very important, keep in mind Fobi's sentence, band removal may result in weight regain. In our experience of 2030 banded GBP until 2016, we had 3 stenosis in 17 elastic rings and 2 erosions. All these rings were removed. With the polypropylene mesh band, 1 contamination of the band that was removed the 5th day, 1 stenosis with band partially removed, and 2 erosions. 1 band removed, the other band left in place. 0.4% band-related reintervention is our experience. This is a video showing the way we can remove the band that is more difficult than to remove a elastic ring, but it can be done with patient with the hook going right to the band, and so with the grasper dissecting the fibrous tissues and adhesions, and finally helping also with the harmonic scalpel. In conclusion, eroded bands can be left to be spontaneously eliminated, or if they cause some trouble, removed by endoscopy or surgery. Bands with symptomatic stenosis must be surgically removed although attempt to balloon dilatation can be considered. Slippage of the band requires surgical removal or replacement. Inadequate weight loss and significant weight regain can be resolved by revision to distal banded gastric bypass or conversion to another more malabsorptive technique. And the sentence of Fobi, band removal without replacement or revision to distal gastric bypass may result in weight regain. But at the end, band-related complications are scarce in the long term and can have adequate ways of treatment. Thank you very much.
Thank you.
Ahmad, go
Thank
ahead.
you. Thank you, Dr. Fobi. Thank you, Dr. De La Cruz, for this great lecture that summarizes your vast experience, really. For us young surgeons, I think the most important thing to me is how do you transition from one technique to the other, and how you evolve from one technique to the other based on your outcomes and patients' outcomes. How did you assess the patient factors, the technique factors that made you move from the silastic ring to the polypropylene and stay with polypropylene as your way with banded gastric bypass?
Well, when in the 19s, I was doing vertical BBG, and when the problems with this technique arose, we changed to Scopinaro's technique, and we saw the nutritional problems of this technique. So there was the moment of perplexity, can say, and now we knew Rafael Capella in Spain in our Congress, and I saw his technique, and I thought that he had the answer to the problems we had with the vertical BBG and the other techniques, and we passing the technique from open to laparoscopy, we thought that was easier to use the silicone ring. And so we began with this, but we had problems. In 17 cases, 5 rings needed to be removed in the first 2 years. And so we switched to the mesh band. That was we talked with Rafael Capella, and he explained us how he did to place the band, and we began with this band, and we have had no problems with this band. Little number of problems with this kind of band in 6.5 centimeters. This is important. The perimeter. I don't know if I have the answer.
Yeah, no, it answered it perfectly. Now, and you alluded to 2 things. Silastic rings are probably easier to revise, but more complications. Polypropylene are probably harder to revise, but lesser complications and lesser revisions. How do you tackle revisions in both instances, silastic and polypropylene? And if you need to intervene in those patient populations, what do you do to prevent weight regain?
Well, if you remove the band, the patient will regain weight, sure. But the silastic ring is very easy to manage in laparoscopy. Many of them can be treated endoscopically, and many of them are spontaneously extruded. You can see the one of these rings in the stomach, and 6 months later you can see nothing there, and the ring has passed. With the polypropylene mesh is a different thing, but erosions in this 6.5 centimeters perimeter, we have not seen. I have no images of endoscopical images of these bands in the stomach. But when in some patient we have reoperated for another question, we have seen that the band was inside in some cases. I am talking about one case of gastrogastric fistula, and we resected the part of the stomach, and we saw that the band was inside. But I think that this band also can be treated by endoscopy, cutting the band, or taking parts of the band, doing partial removal, also endoscopically. And in open, in laparoscopic surgery, we have had an stenosis, and you can free the band from the anterior wall of the stomach and resect the 2/3 or half of the band, and this is enough to resolve the problem.
And once you resect it, do you do anything? Do you distalize your gastric bypass, or do you add malabsorption to those patients?
I think that banding the band in a secondary operation is not as good as in the primary operation. And if you have a weight regain in a banded gastric bypass, better you do distalization. And even if you do, you have a regain in a non-banded gastric bypass, you can add the band, but also add a distalization, because I think that the band will not be so good in the secondary operations than in the first one.
Great points. Thank you, Dr. De La Cruz. And just to mention for young surgeons, sometimes in the polypropylene bands, you go in, lice adhesions, and you don't find the band, and it's embedded within the pouch wall, and you have to dig deep for the band before you actually declare that the band completely eroded, because you can't see it endoscopically, and sometimes you can't see it laparoscopically as well. I'll open the points of discussions to the rest of the panel as well.
Well, at this time, I'll say let's move on to the live surgery. We're running a little late, but it's been such a nice discussion. Would have the fellow introduce one of the consultants, present the patient, and Dr. Bhandari will start the surgery, and towards the end of the surgery, we might have more questions.
Hello everyone, welcome to Mohokoti Complex. I'll be presenting you the brief history of the case we are about to operate. Patient is a 48-year-old female with a weight of 155 kgs and BMI of 46, non-vegetarian by diet, and comorbidities of osteoarthritis, obstructive sleep apnea, and type 2 diabetes mellitus since 1 year on OHS, and with HB of 13.5 and albumin of 4.60. Patient has a HbA1c of 7.1. She is a COVID-19 RT-PCR negative, HIV, HBsAg negative, all viral markers are negative, and ultrasonography is suggestive of grade 2 fatty hepatomegaly. Over to Mohit, sir. He's ready with endoscopy.
Hello, good evening, everybody. Good afternoon and good morning. As we know that at our center, we do the intraoperative endoscopy. We do not do preoperative endoscopy of these patients and do the endoscopy only on the table, specifically in the virgin cases. Preoperative endoscopy at our center is done only for revision cases. So as you can see, this patient has mild esophagitis, I would say. There is no gastritis here. We would try to go across the pylorus to see if there is any duodenal lesion. This is the first part of the duodenum. That's the second. And while I pull my scope back, I can see that the duodenum is perfectly fine. We are not seeing any lesion or anything in the first part. There is mild duodenitis, I would say, but that's fine. This is okay. The pylorus is wide open. Also, at this stage, I would like to see by a retroflexed view the status of the hiatus, because that would help us to determine as to how this patient would do. The hiatus looks pretty fine to me. The G junction is at 40 centimeters. We don't see any other issues. We basically look in the esophagus for any esophagitis, any Barrett's esophagus, any lesion. We look at the stomach for any gastritis, polyp, hiatus hernia, and also for the duodenum for all these issues, because there are certain special contraindications to bariatric surgery for different procedures under different circumstances. Let me focus on the port position at this point of time. When I did the endoscopy, you must have realized that I took around 42 seconds to complete the entire procedure, which means that I'm not expecting a lot of gas inside the small bowel, because we are not wasting our time pushing in a lot of gas. Also, we use carbon dioxide, so that is pretty well absorbed within 1.5 to 2 minutes. Let me now focus on the port position. I'm standing on the right side of the patient. The patient is supine. This is an optical port, which is the 10 mm port, just above the umbilicus. We use two 12 mm port in line with the optical port, both in the left and the right anterior axillary line. We use two 5 mm ports, 2 finger breadths below the subcostal angle, both in the anterior axillary line. So I'm working with total 5 ports here. I usually would not put an Athansens. We use a 3 mm of a non-scarring needloscopic instrument to retract the liver. Now, as far as the endoscopic view goes, we don't see any hiatus or anything. We'll first do the infracolic part just for the paucity of time. Dr. Fobi said we already crossed our time. I just divided this omentum because we were doing an anticolic, antigastric anastomosis. This is the inferior mesenteric vein here, and that's the small bowel. The first step is to arrange the small bowel in a C-loop fashion, and you can see that if you nicely arrange this bowel in this fashion, the counting becomes easier. So I have this marking on my grasper. I can count 10, 20, 30, 40, 50, 60, 70. So, basically the 70 centimeter is the length of our biliopancreatic limb in a banded gastric bypass. We work on the principle of not adding the restriction and malabsorption altogether. So because this is a very strong restrictive procedure, I would not try and add a malabsorption here. So we restrict our limb lengths to around 80 centimeters of the BP limb here. As you can see, we have done that here. So that's 80 centimeters of the BP limb. And now we are dividing this omentum, pardon me, this mesentery very close, because we don't want any pressure on the loop, which is going to go up, the roux loop, going to go up to the gastric pouch. So that's the way we divide it. This is called a scoring of the mesentery. I just go until the base, and then we apply a clip on the BP limb, just because this is a teaching case for the consultants and surgeons. We apply here. We know that the clip is on the BP limb. Although, as I said, if you are arranging the bowel properly, there is no problem. You can see there is no gas in this bowel. So, the beauty of carbon dioxide. Even if you do an endoscopy, I was not facing a problem. 30, 40, 50, 60, 70, 80, 90, and 100. So that's the 100 centimeters of the elementary limb. We can take it to around 110 here. The good length of the elementary limb is anything more than 50 to 70 centimeters to avoid the bile reflux. So this is primarily a restrictive procedure. That's the standard which we follow. Around 100 to 110 centimeters of elementary limb. If we have a very severely diabetic patient with a larger BMI, we might reverse this. So how do we reverse it? We then increase the length of our BP limb to 150 and then take the elementary limb of 110 and take the elementary limb to around 70 or 50 to 70 centimeters. But this is, 6.5 glycosylated HB, as Manoj Reddy told you, and our consultant, and the use of a OHA. So I'm pretty convinced that this is not as severe a diabetes where we need to take a very high amount of BP limb. And this patient can be well managed by a conventional standard banded gastric bypass with standard limb lengths, as we usually do. So this is enteroenterostomy around 6 centimeters. As you can see, there are 2 or 3 ways to close these defects. The first way can be stapled. I'm going to demonstrate a stapled closure here today. Although with the fellows here, we sometimes ask them to close this by suture. I'm going to demonstrate a staple closure. So the best way is to hold it here with one of the ends. The other end can be held in by a Maryland forceps by the assistant. And I can come in with a white cartridge to close it. So this is, a simple way of dealing with this problem is to close it by using a stapler. One can also use suture to close it. But now I will tell you the tips of a stapler. So while you're using a stapler, one has to make sure that you are not compromising on the lumen of the common channel and the continuity of the elementary limb with the common channel. So that's the common channel here. This is the common channel. This is the elementary limb. And we have this nice continuity which is seen here. I have to though take an anti-obstruction stitch just to avoid the kinking of this loop, because this loop, if it gets kinked like that, so that can cause obstruction. So I don't want it to be kinked. So what I'll do is I will take an anti-obstruction stitch. So this stitch will prevent the kinking of my loop. And also it also maintains the continuity between the elementary limb and the common channel. So this is the BP limb here. That's the common channel, and the elementary limb is here. So that's continuity is being maintained. And also it looks simple. When we demonstrate it to fellows, they understand that something which is on the left here is the BP limb. This is the common channel, and that's the elementary limb. And obviously I ask them to trace it back. And once we trace it back, as you can see, trace this limb back for me. So you can trace this limb back here. It goes here. And then when you finally come, this is the elementary limb, which is going to be anastomosed. And obviously this limb is not going to have a clip because we already discussed that the clip was on the BP limb. But this is going to go up and get anastomosed. So that's the part of the elementary limb here, what I have said. And this here has a clip. You can see the clip here. So that's the BP limb. Now we are sure. But this is a big internal hernia defect. See, these can herniate. So the best way to close it is to start from the bottom at the base, because this is wide, and that's the area where most of these bowel would come. With the passage of time, this defect can become small, and the hernia can be a bad one, causing strangulation. So best is to create certain adhesions here so that there is no gap. I'm not saying that you create an airtight closure, but the trick is some sutures, just to create some adhesions which have a lifelong shelf life by using any sort of a non-absorbable suture. Here in this case, I'm using Ethibond. Whatever you feel is comfortable. Sometimes we don't have Ethibond available, we use Proline, but whatever you feel is comfortable for you, use that suture in your practice. It has to be a non-absorbable one like I'm using here. So it is for the lifetime. These are there. I have also used silk here. We have used some barb sutures. Now we get a quill, which is a sort of a non-absorbable barb, which we use in robotic surgeries that we use. It's very good results. Any non-absorbable suture will do. And plus, what I feel is that if you arrange the bowel like how I explained in the C-loop fashion, most of the times what I realized is that we never had problems in sort of identifying the limbs, getting confused, creating a roux and O, and these complications which can happen because that's why gastric bypass most surgeons feel is a very technically challenging procedure. But I realize it's a simple procedure, because if you follow the steps, what we said, and you know where your BP limb is, you know where your rule limb is, and you arrange it like the fashion I arrange in a C-loop fashion, and keep the BP limb on the left side and the elementary limb on the right side and the common channel here. The assembly which I made, this is just a part which can become very simple without any complexity. The moment we try and do things which are difficult, now you see this nicely closed mesenteric defect. We have all three lines is loop nicely lying. There's a common channel, that's the BP limb, and this part is taken care of. And I am very happy with this sort of a closure here. We don't have any chance of having an internal hernia even in future. Now let me go towards the supracolic part. It is an important part, considering because we are doing a banded gastric bypass. There are certain tips and tricks here of doing it. The first is the pars flexida technique, which we follow. So I always see the caudate lobe of the liver and open this area completely wide open so that I can also see the crus. You can see the left gastrix. And now this is the area, where we can expose it. So see, for all the fellows, you can expose this area very easily. So this is the left gastric pedicle. Just try and catch hold of this area. Most times, what you would find is that you would see the pancreas. So yeah, this is the beautiful view of the pancreas. I can use the blunt of my grasper. So I'm not going to go into the debate of perigastric versus pars flexida. All I can say is that our center, Dr. Fobi would do a perigastric, I would do a pars flexida. Our results are the same. There is no outcome of doing partial or complete vagotomy on either rate of marginal ulcers or any other outcome. So we are now, because it's simple, pars flexida, we are now following this technique. We have a lot of data from Phil Shower and colleagues and several others now who follow this particular pars flexida technique without having complications of either problems of gastric emptying from the pouch or all those sort of issues. So now this is an established technique. I have performed close to, I can say, 5,000 gastric bypasses by this technique, and we never changed this since our first bypass we did. So pretty satisfied and absolutely no problem. Now at this stage, I can have one of the blue cartridges to fire. My landmark would be 1 centimeters below the left gastric pedicle. I come and fire one blue load. So I'm just going to go a little bit up here close to this, and this is a blue load. So we will measure the length of our pouch, exactly how much it is, but just let me complete this firing. So you can see that this is here. And now what I would do is I'll use a harmonic to little bit dissect the posterior part. So I have some additions here, which I did not expect, but this is crucial to just use the blunt dissection. And once we do this blunt dissection, not too much of energy source, just with the grasper, we can do, you can see that I opened that area close to the left crus of the diaphragm without using too much of energy source and, a lot of different fancy devices, just simple use of grasper. So we are here and I do this also in mini gastric bypass. I don't use any energy source. This is something special we do. We have done close to 6,000 one anastomosis bypass. Never did we dissect close to the angle of his, doing a lot of dissection there. Now I will ask the anesthetist to come in with the bougie. So you see the bougie is there inside. It's a 38 French bougie which I have. I'm just make sure that it is there. Can you push the bougie please, so that everybody can appreciate? Beautiful work done. I'm just gonna go a little close to the bougie. Just I want my 7 size band to be nice, loose with my pouch. Can you give me a clip please? Push the bougie please. Push more. Push more. Very nice. Very nice. So this is a very simple method of hemostasis. The clips. I would now use a little bit of harmonic. Take one more clip, please. Take one more clip, please. So I don't want to spoil my field. Now I will take a harmonic and do a little bit of dissection here. Usually I don't require to dissect too much, but I'll take the gastrophrenics because this makes this plane look more nice to me without damaging the spleen. Sometimes if we do not mobilize the gastrophrenics, the spleen being closed here so much, I can damage the spleen. But I use my grasper effectively to disconnect this pouch. Once the pouch is disconnected, we're going to keep a gauze there, and just any bleeding or something can stop. So this gauze can be kept there just for the purpose of small, because the fat is there. Fire close to the angle of his, there's fat at the fundus. Can you push the bougie, please? So now I will take a ruler here just to demonstrate the length of my pouch. It's a little bit longer, than most surgeons would do. So you see, we start from here, so it's, I would say, around 6.5 centimeters. And we usually create and put the ring 2 to 3 centimeters below the G junction. So that would be here, and around 3 centimeters below the G junction. And then once I put the my grasper, I'm gonna insert the band. This is a pre-sterilized, prefabricated band by Bariatric Solution. I have used Gappy rings for the initial 6 to 7 years of my practice. After it was the production stopped, and then I started using my own handmade rings, which Professor Fobi brought in the material from US, and we made for patients who cannot afford it. But we use minimizer ring now, which is very nice. The benefit of using this ring is that, as you can see, and I think Professor Luke Lemmens also uses this now. It's been using for a long time, and both of us, we agree that this ring has certain inherent benefits. Of first is that we can calibrate it on table, and this design has that property. And if you see, the slots are there. So this is 7.5, and I can put it at around 7.5 here. I want it to be a little loose. There is a little bit of fat here, so I would have gone for 7 usually, what Professor Fobi recommends. But I see that what my estimation is that because of some little bit of fat, I'm just going a size above that. So that's the beauty here of this particular design of the ring by Bariatric Solution, that I'm able to calibrate the ring on table. And if you talk to Professor Lemmens and all others who have done these procedures in thousands in numbers, they would say that there is a benefit of using a pre-sterilized, prefabricated ring, and you can do a good amount of change of calibration inside on the table, which is not possible by a ring which you create by making some material. So push the bougie. Now you can see that the bougie is pushed. I'm going to make a small gastrotomy here. Why I say a small one? Because I don't want to dilate this defect a bit too much. Push the bougie, please. And you know what I do? I take full help from my anesthetist to make this gastrotomy. Why? Because I make it over the bougie. Most times, it's very easy to make it on the bougie. And once you see the blue of the tip of the bougie, you know that you are at the right plane. So this is done. Now, this was my rule limb. As you saw, I have put it in a special location there, just above the colon, so that it does not drop back. Now, I am working in a supine position, but the beauty of how we do these things is that we never had a problem of this limb dropping down, just because of the assembly we created between the small bowel there down in the infracolic area. So I come here with my blue load, and we're going to do an anastomosis of around 2.5 centimeters. Sometimes we take a little larger, but while we suture it, it becomes 2.5. Push the bougie, please. Okay, so now you see another benefit of having the bougie pushed. You can go inside by a railroading pattern with the help of the bougie. So you can see here, I am inside. I'm going to take around 3 centimeters of the anastomosis. So this is 3, as you can see. And once I fire and I suture, it's eventually going to become 2.5. We usually just do a post-op bougie test to see the patency, but here, because it's a teaching case, I'm going to do an endoscopy post-op to demonstrate how the internal anatomy looks like. We were doing in the initial part when we had a bariatric endoscopy fellowship, we were doing a bariatric post-op endoscopy immediately post-op in all the cases, just to keep our fellows, more oriented towards this anatomy, because I see that most surgeons are not oriented towards the internal anatomy, and when you face complications like marginal ulcers, if you are not very well versed with this anatomy inside, then there is a problem. So now let me close this defect here. So you can see that I first go inside, and then I'm going to do a Conal's throw. So this is a very standard practice of closing the enterotomy defects. You can see I'm exposing the defect first. So I'll just put this loop a little bit here, so that we are able to properly expose this defect. It's very important in teaching case. You see, I took conal here, so I was inside. Now I'm going outside, and then I again come inside to out. So this is securing the caudal end of the anastomosis. I can use my endo stitch to just rotate this very softly, the small bowel, so that I'm able to see the posterior part, the corners pretty well. These are the corners which are difficult to close, but if you just rotate your small bowel by using a nice endo stitch device, just like a small rotation like see I'm doing here, we can easily take care of this. Again, I'm seeing the angles properly. I'm not blindly closing it. The angles, most times, once you try and close them properly, you can sleep peacefully. So I'm happy here. Last one I will take, and then again when I take it, I expose it properly. So you see the corners being exposed. So this one, and this suture stabilizes and secures my caudal end, and I'm going to cut it here. I'm going to cut it and then going to come from the Kiffelard end. So I can go continuous, continuously I can go suturing, but I'll just cut it here just for the purpose that I don't want that we sort of okay, just cut this. So I don't want that we compromise on the entire length of the suture. So I will cut and come back. And also sometimes if you have a loose knot in between, the entire anastomosis is jeopardized. So I just take it two ways. I first secure one of the ends and then come from the top end to the bottom. So that makes sure that first my suture length is sufficiently used. And the second is that I know that if I have a loose knot, I'm not jeopardizing the entire anastomosis, but at the same time, I'm sure that I have secured both the ends separately. Also, this gives me the freedom to do a little bit of triangulation. As you can see, I'm standing on the right side to do these anastomosis. I see most surgeons, they stand between the legs. We have seen one of the stalwarts, Professor Higa, he stands between the legs and does a beautiful suturing, 4-layer suturing, all hand sewn by triangulating by this stay suture. In endo stitch, the beauty is you don't require to triangulate that much, but then still, you see how I'm using this suture to just, rotate and sort of use the entire area to my advantage. So that's the small trick for young surgeons, that you can use this, put it in any direction. If you take it towards the left side, you can expose this. If you take it towards the right, you expose the other side. So just using this to your advantage, the stay, and now I can come and take a surgical knot so that it is completely locked and secured. So you can see the surgical knot is easy to take in endo stitch device. We come one way and we go the other way. That's it. So this is the end of my anastomosis here. I'm going to do an endoscopy and just complete the procedure for you. But before that, two important steps are left. The first is closure of the Peterson space, and then fixing and securing the ring. So let me first demonstrate how we close the Peterson space. This is a teaching case. So I have received requests on the Zoom platform by some of the surgeons to demonstrate our technique. The first trick to properly close a Peterson's is to properly expose it. How do we properly expose it? We make the patient head down, right? And then what I do, I tell my fellows that take a pre-knot suture like what I have taken. So you have your assistant's hand free, and your hand, so one of your hand is rotating the transverse colon up towards the gastric pouch, which exposes the space. The second hand is using the suture, and one of your assistant's hand can help to basically pull the tissue and follow the suture for you. So this is the advantage of using all what you have in your armamentarium to the fullest, like a teamwork. If suppose you are occupied with suturing, taking knots while you are beginning to suture here by Peterson space, what we realized, I cannot rotate this. So I just leave this here and I have to focus it. But now I have this left hand free. So I can very nicely expose my Peterson space. That's why I ask fellows that you take a very nice pre-knotted suture, so that you have good amount of exposure by one of your hands in this area, and that exposure matters. What I realize now, I am exposing here, it is not dropping down, so I know both my edges very clearly, and then I can just come and take small bites, not very thick or deep. Sometimes we end up having some hematomas here, but just sufficient enough to create adhesions like we did to close the mesenteric space there. So that's the final end of our Peterson space closure. I will demonstrate you how we ended up that space look like once it is closed. So you can see here, I'll cut this suture. I'll use the same suture to save it for the purpose of fixing the ring. Let's see here how it looks like. So you see, this is the defect here, and just completely closed. That area, that was a large defect, and we completely managed to close it. Just the 2-3 tricks which I said. Take a pre-knotted suture. It is going to help you to have more exposure. Use your assistant with the Maryland. Now this is the ring which we are going to fix. So there are two landmarks. You fix it 2.5 to 3 centimeters below the G junction, or at least 2 to 2.5 centimeters above the anastomosis. So that's what we're going to do. Bariatric solution provides a nice, beautiful socket here to fix this ring, and we're going to use that socket to fix it. So that's it. This is the end of the procedure. Now, just to complete it, I'm going to come with an endoscope, put the scope across into the small bowel through the gastric pouch, just to demonstrate that the patency is there. There's no internal bleed. We do not usually do it. If I would have been doing as a non-teaching case, routinely I would have ended this case up and gone with a anesthetist would have gone with a bougie just to check the patency. We usually do not do any leak test. We don't put Ryle's tubes or drains. We even do not put catheters until patient has some special problem. So you see, this is a G junction. This was the esophagus. This is a G junction. Obviously, I expect a little bit of blood. It's a fresh anastomosis. This is the nice staple line. So you can see the length of my pouch is around 6 centimeters measured by the endoscope. This is our anastomosis. That's the the dead end, or we can say, and then I'm going to go here. So you can see nice, beautiful looking anastomosis. I'm not going to go very much into the small bowel because I don't want to dilate it too much. But while I pull my scope back, I see nice anastomosis here. You can see there's no bleeding at the anastomosis. And you know why I want my bariatric endoscopy fellow to get oriented to this anatomy? Because you see, these are the places where you find our marginal ulcer here. So we need to be oriented about this anatomy. And once we are oriented, it gives us a lot of benefit in terms of understanding them in post-op surveillance. At this stage, I would be ready for the questions while the patient would be extubated. Thank you very much for kind and patient listening.
So, Mohit, Caetano here. Very nice surgery.
Hi.
As always, I've been seeing your surgeries, and I'm really got impressed. And I saw the surgery first time when I went there in indoor and met you with you have a very, very nice service there, a group, a team, and we know that it's a teamwork. All surgeons, we do understand that doing surgery is not about only the surgeon, but the whole teamwork doing around us, helping us to make things happen. A question about the band. Eventually, the way you clipped it, is there a chance it can be unclipped without any pressure on it for a defect? And if in that case, did you ever seen it, and how to solve the problem? You go back to the
so we can easily remove that band. It's easily removable as long as it's not eroded. If it's eroded, we can easily unclip or unlock it. I would say the correct word would be unlock it. If it's eroded, then probably we'll have to use an endoscopic scissors and then cut and remove it. But if it's not eroded, and there will be some, if you go after 2 years, I have videos where you will find minute, very beautiful adhesions being made around the band. Nice. You can cut through that capsule. It's not that bad a capsule which you get in an adjustable gastric band. This capsule is more flimsy. It's more forgiving. So cut around it, and you can easily unlock this band and remove it. That's my experience.
Thank you. Thank you.
Ahmad?
Great technique, Mohit, and looks very standardized. The questions that I wanted to ask you is, when do you use the band? Is there a patient population that you use the band on, or versus others? That's one. And is your technique the same in banded and non-banded exactly, or do you do something different in the non-banded group?
Ahmad, fantastic question. So first of all, let me tell you, I seldomly perform a non-banded gastric bypass. I don't believe in it. I don't believe in a conventional gastric bypass. We would band all our bypasses, but if the patient has given a negative consent and a video consent that he is ready for the weight regain 5 years or 6 years or maybe 3 years sometimes after a non-banded bypass, and he would not want a band, we do not put a band. If the patient say I cannot afford it, we put it in very minimal cost by using our own self-made bands, by using the silicone material. So me and Professor Fobi, we believe in this concept, not because I have any conflict of interest, because now I see my own data. So what good thing I learned from Professor Fobi is that sometimes we do not learn from our own experience. So we have a prospectively maintained database which clearly depicts and reflects that absolute no to a non-banded gastric bypass. We have almost 60 to 80% of weight regain. So this is the first answer to your question. Now, if I do, suppose I do a non-banded one, what difference would it be? There is no difference. The length of my pouch is around 6 centimeters. Absolutely same. Absolutely same. I have gone to lengths below 6 centimeters, making a very, very small pouch, 3 to 4 centimeters, but I think it only increases my rate of complications without any added benefits to weight loss. We have data, 3 meta-analysis on the volume of the pouch and the length of the pouch. And as you know, all 3 of them have very clearly established that the length and the volume of the pouch in long run does not matter in terms of what sort of weight loss we have. It matters for the marginal ulcers. Oh, absolutely. Absolutely. It matters for margin, not for weight loss. So there's no change in my technique.
So my following question, before, if you allow me, the band itself challenges the notion of the metabolic mechanism of bariatric surgery per se. I mean, from Reddy's talk, you notice that patients with longer biliopancreatic limbs achieve probably better weight loss as opposed to banded gastric bypass. The advantage of banded gastric bypass would be maintenance of weight as opposed to better weight loss. What's your take on this? Given the chance, would you use the same for both techniques, banded long BP for certain patient population, or you don't?
So I mentioned during my presentation or my surgery, in virgin patients or those who are having primary surgeries, we don't combine restriction with malabsorption. That's a bad policy. If at all we learn something from Professor Scopinaro, the great Professor Scopinaro, is that do not combine the two. And innumerable number of examples where we had very high complication rate, including malnutrition and liver failures, where we combined a very long BP limb with a banded bypass. So no, I do not combine them usually. There is only one such circumstance when I would combine, as Ahmad, you asked me, and that would be distalizing a failed bypass. So our center's technique is pretty standardized in that sense also. If we have a failed bypass, we redo the pouch, resect it, redo the anastomosis, put a band, and then we distalize this like Sugarman's type 1 distalization. So that's the only circumstance when we would go for combination of a restriction and malabsorption, like you very nicely and you elaborated very nicely upon that. But there we would take a consent that the patient might end up having liver failure and malnutrition, and plus we would make sure that we have a very good follow-up. Patients in India should bear the cost of supplements, understand about that kind of malabsorptive nature of the procedure. That's the only circumstance. I also agree with you that if we have a very long BP limb, we are increasing the weight loss and the metabolic strength of the procedure. But I haven't compared my standard banded gastric bypass with a non-banded long BP limb bypasses. So I cannot tell you the real story. I think it's a very nice idea of research you have, you basically gave me while in this discussion, that can we compare a long BP limb non-banded bypass with a banded conventional bypass and see if the results are different.
Especially from the quality of life standpoint.
Oh, can I comment on that also?
Go ahead.
So, of course, a very nice procedure, Mohit. I completely agree with everything you have said. On the other hand, we have not to forget that if you, by making a linear anastomosis, you shorten the pouch by another 3-4 centimeters. So what is left is only a pouch of 4 centimeters. So, and you put a band above. That's why you don't have to. We should make the pouch too short, especially if you do a linear anastomosis. If you do a anastomosis, then of course the pouch stays a little bit longer. A second remark, and I think that's for the youngsters, when you put the ring the way you did it, and I did it also, and I still do it sometimes like you do, is when you put the stitch for fixing the ring through the staple line. It's very good because it stays well in place, but you don't have to close the knot too strong, because this will cut through the staple line and it can cause. It can be a reason of a leakage at that point. So if you put your ring, close it, but don't close the knot too strong. It's very important point.
Very nice, very nice tip. I think. No, very nice tip you gave. In fact, Professor Fobi for one time was against taking it with the staple line because we had some erosions, not here but in banded sleeves. So he told me that when you take these sutures, don't go very deep. As you correctly said, don't be very tight, respect the tissue. We never had these problems with bypasses, but we had some of these issues with our banded sleeves where, we fix the ring pretty tight, and sometimes there was a suture because this suture is a non-absorbable. So it goes inside, and if it goes inside the lumen, it can cause erosions and it can make a ring more prone to erode or maybe a leak. So I agree with you. We have to be cautious, specifically in sleeves where you put a band.
Great. Felipe, any comments?
I have a question.
Okay,
first of all, thank you so much, Mohit. This has really been fun. Regarding the banded sleeve, how far from the gastroesophageal junction do you place the band?
Beautiful question, Rachel. So 3 to 4 centimeters. Essentially, what we were taught is that if you have a lot of pouch above the ring, it's going to create an hourglass. Number one, it's going to cause a twist. Number two, it's going to cause a stricture. Number three, and that is not what you want. What we think is that we are trying to apply the same principle of banded bypass to a banded sleeve. So never below 4 centimeters from the G junction have I applied the ring. Whenever I have done, I have faced complications.
That's also maybe another remark, especially in reduce, when patients are going back and you put the ring again on the good place after sleeping or whatever, always tell them not to go to solid food before the first 3 weeks, because you have to wait that the ring is fixed again by some fibrous tissue, because this tissue will not keep the ring in place, especially with a large food bolus. So that will push the ring down again. So this is an important thing. Just tell them, but also after the first operation, primary banded bypass or sleeve, I tell them not to eat solid food for at least 2 weeks, so that the ring has time to fix himself.
Thank you so
Absolutely.
much, Dr. Lemmens. That's the kind of thing that young people need to hear.
Absolutely. Absolutely.
It's very important.
Thank you.
There are 3 other things we want to point out. When you use a ring, you must have noticed that that ring is loose around the pouch. That is why banding the gastric bypass, the sleeve, or any other procedure where you form a pouch is different from doing an adjustable banded procedure. With an adjustable banded procedure, you place the band right on the stomach. With the non-adjustable ring, like has been used in this case, during the first 5 months, the patient who has a band does not know the difference from the one that did not have a band, because they don't feel the effect. They only start feeling the effect when that pouch stretches to meet the restriction of the band. And that's the main reason why there's less incidence of erosion when you do a non-adjustable banded gastric bypass or sleeve. The second thing which Dr. Lemmens has mentioned, you want to make that pouch small. Never make a pouch longer than 4 centimeters. Laplace law says the wider, the longer, the more it dilates and it forms an hourglass. In my practice, amazingly, with more than 7,000 banded procedures, I never had a mega esophagus. I don't know why. But Luke said something which is important. When you start doing the banded procedures, you have to talk to the patients. You got to chew, chew, chew. You have to eat slowly, and you have to chew your food to smithereens. We learned this from Dr. Mason when he invented the vertical banded gastric bypass. If you read his textbook, he says, the only way the banded procedure would work if the patient adjusts to the procedure and learns to chew. And like Lemmens says, most of these patients learn to chew. And when they learn to chew, they'll rather have a banded procedure than just eat regularly. Ideally, when you think about it, you think that these patients have vomiting, but very rarely do you have it after 1 year. We're doing the study and we'll be talking about that in a surveillance thing. But let me just ask Dr. Den Bossche if he has any comment before we have Mohit close up the session.
Yes, I have a question for Mohit. An excellent demonstration. It's very slick. It's very impressive. I've got a question about the bands. I mean, I used gastric bypass rings until they were no longer available on the market. But you did sometimes see breakage of those rings. And I got some patients who still have a broken ring in place. Now, have you ever come across a broken minimizer ring or not?
No, I've put a lot of minimizer, I think more than 1,000 cases, never had. When I was using a gappy ring, we had some cases of not broken, but open ring. Sometimes it used to open if we did not lock it nicely in place, because the oldest version of gappy ring was a little tough to lock. So I was learning that technique from Professor Fobi in 2013, and we were together doing these cases here. I had one such case where I could not lock it properly, and I had to go inside to lock it again 3 months later, because I could find on the x-ray that the ring was open and the patient lost all restriction.
Yeah, I remember those rings with the 2 prongs. They were
yes. But me, I found a very beautiful way. And, you know, interestingly, Professor Fobi would agree, when the gappy ring was tough to lock, I was the only surgeon able to lock it in most of the live workshops. And I found out a trick around locking it very beautifully.
I used to give them a little squeeze with a
absolutely.
Sort of
absolutely,
so they would fit in the.
But I can absolutely. You made me feel nostalgic about those rings, but let me tell you, those were the most robust rings I've used in my life, because once they're locked in place, even today the patients are doing fantastic. Absolutely no weight regain. That was the mechanism of that. It was tough to lock. It was a big deal breaker, let me tell you, those old versions, and you would agree with me. But once you master the technique to lock it, your results over a period of time were fantastic. Dr. Fobi and the company discontinued with that prototype. now they have the same like the bariatric solution, probably coming into the market. But you made me feel nostalgic about those old days. I used a lot of those rings. In fact, until 2017, I don't remember correctly, but for 5 years I used those rings. And there were 2 years when no surgeon were able to lock it in the live workshops. It was very embarrassing sometimes.
I still have a few boxes with 6 centimeter rings that never got used.
Oh, beautiful.
Okay, let me just close by saying these are the takeaways from this meeting. The banded gastric bypass is not for everybody. Dr. Moore asked a question that wasn't addressed. When will you not do it? Definitely, these patients have to chew their food thoroughly. So if you have somebody who has dental problems, don't give them a banded procedure because they're going to form bezoars in the stomach. We have an algorithm at Mohawk where we use the gastric bypass, the banded gastric bypass, the one anastomosis gastric bypass, and a sleeve. So we do not give it to everybody. It's not everybody has a banded procedure, even though it's a good procedure. Patients with diabetes or super obesity preferably would have a one anastomosis gastric bypass. If those patients have a hiatal hernia or GERD, then they are offered a gastric bypass. If the patient who deserves to have a one anastomosis gastric bypass cannot afford to take the supplements, then they have a banded gastric bypass. If they live far away where we cannot follow them, then they have a banded gastric bypass. So we end up with about 30% of the patients having a gastric bypass and about 35 to 40% of the patients having a one anastomosis gastric bypass, and the rest have a sleeve. So we have an algorithm and we do select the patients, and the patients are informed about all the procedures, and we decide on what to do. And that's why we can do intraoperative endoscopies. Before the endoscopies, the patients are assigned to, for instance, if a patient comes in with a history of taking PPIs, or has a history of a hiatal hernia, or has a GERD, that patient is automatically assigned to a root-wide gastric bypass. That's why our conversion rate is not high, because the selection before surgery has sorted out some of the patients. The only time we convert is if we incidentally find at the time of surgery that a patient that was scheduled for one anastomosis gastric bypass has a hiatal hernia or endoscopic esophagitis, then that patient gets changed to a gastric bypass. Or if we go in and find out a patient who is supposed to have a one anastomosis gastric bypass or a regular banded gastric bypass has polyps or any peptic ulcer findings, then that patient gets a sleeve. So that's the algorithm we have, and Dr. Bhandari has followed it, and so far we've minimized the problems that patients have. I would like to thank all of the faculty members for your participation. This one took a little bit longer because it was interesting and there were a lot of questions, but we normally finish in 2 hours. This has gone 2 hours, 35 minutes. Thank you all very much. Mohit, tell everybody thank you. We're not having a session next week because we're celebrating, I think, Holi in India.
Yes, absolutely.
We're celebrating Easter. So the next session is only going to be on February 12th. At that time, we'll be talking about the banded sleeve gastrectomy. You're all invited to tune in. And again, thank you to faculty members for your time. Mohit?
Thank you. Thank you, everybody. This was, I think, I would agree, one of the most brilliant, one of the most interesting discussions we had today. And, even though it was long, all of us were glued. Thank you very much for making it and devoting this very precious time. Please keep safe. The number of cases are increasing in our country and I think across the world. I just came in from Nairobi where I went for a support group via Dubai. And let me tell you, the airports are deserted. The same thing has started to happen. The most unfortunate part is that now we will not go into a state of lockdown due to economic problems here in India. So we might have a surge of case. I wish all of you very good luck. I hope all of you are vaccinated. Keep safe. And thank you very much for attending this meeting. And we hope to have you again soon. Thank you.
Thank you.
Thank you. Bye-bye.
Actually, do you have promo next?
Thank you.
Thank you very much. This is recorded and it can be accessed from the VBU website with all the previous VBU lectures. Thank you very much. See you on April the 12th for the next session. Have a good day.